Hello, this is Ginny Cover. I'm a board member of Access. Our speaker tonight is Dr. David Hong, a child and adolescent psychiatrist at Stanford University. Dr. Hong serves as a principal investigator in the Center for Interdisciplinary Brain Sciences Research. He's interested in establishing clearer links between genetic risk factors and neurocognitive phenotypes, including X and Y variations. Dr. Hong is the medical director of Stanford University's clinic that provides services to children and young adults with sex chromosome aneuploidies. Before the webinar, let me tell you how Access handles questions for the presenter. The mics are closed because we expect a very large audience tonight. If you have a question, please type it in the question box on the lower right-hand corner of your screen. If you've called in on your phone, then you can email the question to me at info@genetic.org. That's info@genetic.org. We'll take as many questions as we have time for at the conclusion of Dr. Hong's presentation. And now I give you Dr. Hong.
Thank you for that nice introduction, Ginny, and welcome everybody. It's a real pleasure for me to be able to join you today. It's always a delight to go to any of the Access meetings and to meet all the families. Like Ginny said, I am a clinician. I'm trained as a child and adolescent psychiatrist, and part of my practice is working with young men who have various X and Y chromosome variations. So the talk today is really focused on a lot of the questions I get from families that come in to see me, and it's really trying to understand the various aspects of what can be a very confusing system, which is navigating the mental health clinics and that whole domain. So I think a lot of families do get really good guidance early on from genetics and endocrinology, and maybe even reproductive endocrinology and fertility. But a big part of development, especially in school age and adolescence, will be issues that arise perhaps around behavioral or learning and cognitive issues. So the goal of today's talk is just to introduce you to some of those concepts. Some of you guys may have already encountered some of these issues, and others may be totally new to it, and just trying to get some anticipatory guidance about issues that might come up for yourself or for your children. And hopefully this will be a kind of nice broad introduction into that whole topic. I forgot to put my disclosures on here, but I do receive funding from the National Institute of Mental Health for my research. And then as well, I do some consulting to a parent media company. So those are my only financial disclosures. So let's go ahead and get into the talk, and we'll leave some time at the end to answer questions that you guys might have. And the title is Navigating the Mental Health System, A Guide to Treatment Options. So a lot of this material is something I covered in the meeting a couple of years ago in conjunction with Dr. Tartaglia. But really the agenda for today is to try to get a global understanding of symptoms that are associated with X and Y variation. And I want to walk you guys through what is a typical evaluation process once you start thinking about some of the conditions that might be associated with the diagnosis. And then for a kind of broad overview, I'll give you a general snapshot of what the most commonly used interventions are currently in our field for any particular diagnosis, and that also includes an overview of medications. So I think the first kind of context is really just thinking about how common psychiatric disorders are in general in the pediatric population. And that will sort of serve as the backdrop for understanding whether or not having a genetic condition like XXY or XYY might put you at lesser or greater risk for any particular condition that already exists fairly frequently in the overall population of children. So this is CDC data, and we're looking at what's considered 12-month prevalence for children in that general age group from elementary school age to adolescence. And you can see that psychiatric diagnoses are fairly common in this 1-year prevalence module, essentially. So up to 13% of kids will have, within the last year, any of these psychiatric diagnoses. And you've probably heard a lot about the most common one, which is ADHD. And attention deficit hyperactivity disorder, unfortunately, is the most common chronic behavioral condition now in children. But that's followed by a number of other conditions, including mood disorders, such as major depression, conduct disorder, which is a behavioral issue, dysthymia, anxiety disorders, and other eating and anxiety disorders. So if you really separate this out, you could think of potentially development as happening in several stages. And there are probably some differences in the sorts of diagnoses that you'll encounter depending on the age of a child. And if we look at childhood, which is really pre-adolescence, you'll see that the more common diagnoses are things like ADHD, learning disorders, and autism spectrum disorders. Anxiety disorders are also very common in this age group. And we often kind of wrap these sorts of disorders that happen early on as neurodevelopmental disorders of childhood. What's very interesting is that there's also pretty prominent sex differences early on in these conditions. And you can see that there's a predisposition for males to be more likely to be affected by some of these neurodevelopmental conditions, including ADHD, learning disorder, and autism spectrum disorder. And then if you go into adolescence, as things change biologically, puberty starts, there's a lot of physical and emotional, social changes that are occurring at once. And if you look at these broad adolescent surveys that are done nationally every couple of years, there's some shift really in some of the diagnoses that are more prominent between boys and girls. And now there's an emergence also of more female predominance in things like mood and anxiety disorders and eating disorders. And you'll see higher rates of things like MDD and eating disorders, which really isn't common in the child population at all. So that sort of sets the stage for trying to understand how X and Y variations would kind of present against that context. So many of you are familiar with Dr. Tartaglia's work and Dr. Boada, who's the neuropsychologist. And this is the team that's all in the Colorado clinic. And she's been doing a lot of the early work and really trying to understand specifically how should we think about psychiatric diagnoses or cognitive and behavioral diagnoses in the context of having sex chromosome aneuploidy. And so this encompasses a fairly broad band of karyotypes, right? It's including, you can see both the XXY, XXX, XYY, and then even more complex karyotypes, but fairly less common, are the XX and YY, for example. And what you're seeing in the figure in this table, this is one of the tables from the paper, is they looked for different kinds of diagnoses that were given in these different categories, right? They looked at the prevalence of things like intellectual disability, learning disability, a mood or behavioral disorder, autism spectrum disorder, tics, and seizures. And you can see when it's broken down by karyotype that they have simply the number of kids out of the total in each group and what percentage that represents. So in all these groups, you know, you would have, for example, 5 out of 56 kids with XXY who had intellectual disability, which represents 9% of that population. And the way to test if that is meaningful or not is they did something called the chi-squared, which is if there was no impact of having this diagnosis, you know, would this frequency be observed? And what this denotes here is like, you know, the likelihood that this is not just chance. And the asterisk indicates the diagnoses that might be more significant, right? So as you're going down in each of these columns, for example, in XXY, you're seeing certain numbers of kids out of the total number of kids that have it. So there's higher rates, like 63% of the kids with this diagnosis had learning disability, 29% had a mood disorder, and autism disorder was 4%. And there's kind of similar elevations along the different dimensions as you go across the different diagnostic categories. And it's particularly pronounced when you go past the triploides, we call them, when you get into the 4 numbers of sex chromosomes. So they appear probably to be more likely to have some of these conditions that are commonly found in children. So when we look at the significance, is this really a difference that you would expect to see? You can see that probably it's particularly pronounced for things like ADHD, or I'm sorry, intellectual disability here, learning disability, and then autism spectrum disorder. So keep those diagnoses in the back of your mind. I mentioned also ADHD. They looked at that specifically as well. And using the different kinds of rating types from parent and teacher rating forms, they were looking at the prevalence of not having an ADHD diagnosis, parent ratings showing that they have either an inattentive, hyperactive, or combined type. So there's a question I get from a lot of families now, is really trying to discriminate between the subtypes of ADHD. So I think, you know, in the past, people used to think, oh, well, if you don't have the hyperactive piece, you'll have ADD. And then if you have the hyperactivity piece, and it's going to be called ADHD. And really, for all intents and purposes, that's one way to think about it. But the way we categorize it clinically is we call all of them ADHD. And then we simply separate the diagnoses into the kids who have predominantly the inattentive presentation, we call it, or predominantly the hyperactive impulsive presentation, or both in the combined type. And again, we'll see here the percentages of kids who had, for example, no ADHD diagnosis, so 60, 24%, 48, 28%. And then based on parent ratings, kids who met the category for inattentive. So it's up to 34%, 49% in XYY, 44% in XXX, and then 53% in the XXYY karyotype. Much less so of just the hyperactive, and then slightly elevated, or, you know, it's much more variable here in the combined type. But for the any subtype category, it's from parent ratings alone, you'd see that it's a significantly higher percentages than you might expect. So for the general population, we often will say that the prevalence of ADHD is around somewhere between 5 and 10%. Most people give a figure around 8%. And since it is skewed more towards boys, we would say it's probably 8 to 10% at around for neurotypical boys. So when we're looking at these percentages of seeing up to 36% of kids in the sample, or 76, 52, that's almost 3 to 6, 7 times higher than you would expect compared to the general population. So certainly a much higher prevalence of these diagnoses in our kids who have X and Y variations. If you recall, another one of those general categories that is seen is in the domain of autism spectrum disorder. So for those of you who aren't necessarily familiar with autism spectrum, it's really a defined syndromic way of diagnosing social cognitive deficits. And this has been identified as something that boys with X and Y chromosome variation might be more at risk for. This is, I think, a nice visual representation of how to understand that. One of the kind of screening or measurement tools that we use is something called the social responsiveness scale. And what this is really a parent questionnaire about a number of different domains of social behavior. So it might be things like social communication, like how effective you are at different ways of communicating socially. Reciprocity, like how you engage in a back and forth social interaction. Social motivation, all those sorts of things. And what I like about this figure and what I think it can tell us is it really illustrates the fact that everyone is different, regardless of the kind of genetic diagnosis that you have, right? So we're going to look at this curve or this distribution as what they've termed as kind of the normal or neurotypical distribution of scores. So the way that this particular measurement works, the social responsiveness scale, is that the average for the population is normed around a score of 50. And so you can see that there's just going to be naturally, regardless of whether you have a diagnosis or not, just...
Rick, we lost audio.
Hello? Should I hold on? I don't know if you guys... I want to make sure people can hear me.
Audio still sounds good to me.
All right. I'll continue, and then please jump in if anyone's having trouble hearing, and I'm happy to hold on. So getting back to this kind of measure of social cognition, you can see that there's just going to be a peak. Most people are going to fall generally in a certain norm of what we consider to be kind of the average range of social behavior. And then as you get into the more to the ends of scores, like these more extreme scores on either side, those would be sort of the outliers, right? And for this particular measurement, the higher scores sort of indicate that you have more difficulties maybe with social communication or social behaviors. So based on this particular sample, they looked at these 3 different diagnoses. And as you can see, just as in neurotypically developing kids, there is a distribution. There's going to be a big chunk of kids who just fall within the normal, what we consider the normal range of social behaviors or social scores for this particular test. And for XYY, that's this whole bunch of kids that are in this range. But you can also see the general mean of the score shifted over, right? And so the peak is somewhere higher on this scale. And that's because there's probably more kids who fall in this range of having difficulties on some of these social behaviors. And again, this is just another way in clinical or research ways we can use measurements to sort of look for things that might, our kids might have particular vulnerabilities for. So, you know, just surveying the literature, I was looking for different kinds of diagnoses that are commonly reported or that have been studied systematically. And like we covered on some of these papers, there are increased rates in a number of dimensions. So the ones that we'll spend particular time discussing are things like attention deficit hyperactivity disorder. And again, the rates there is up to 35 to 50% of samples that were kind of assessed fell in that category. Super high again is learning disorders, and very specifically, it's not every aspect of learning, but particularly language-based disorders, or often what we'll call dyslexia, which is related to reading. And in some figures, it's as high as 50 or 75% of these samples will have kids who've had some kind of school referral for additional help in these domains or have a formal diagnosis. There's a lot of work also in Europe around the correlation between having a XXY karyotype and increased risk for things like schizophrenia, which is a primary psychotic disorder. And then, as we've discussed here, the increased risk also for autism spectrum disorder. Lastly, there's also mood and anxiety disorders, which are more pronounced probably, but fall closer to the range that you would see in typical populations. And the reports for these are much more variable, suggesting that there's a lot more kind of differences potentially methodologically in how the studies were approached. But there does seem to be an increased incidence of these diagnoses as well. And an interesting thing to keep in mind is even in youth and adolescents who don't have X and Y variation, these disorders or these particular conditions tend to be male predominant. So especially for a lot of our kids who do have, who are, you know, by definition, who have these Y chromosome variations and therefore are male, they are already predisposed to risk by the nature of their sex or gender. So I think one question that often comes up in clinic with families is, what are we supposed to, how are we supposed to think about these diagnoses? What do they mean? biologically, or what are it's tied to? What is it useful for? Because often the genetic karyotype will precede, for a lot of families, these other things that come later in development. So especially now with increased access to early genetic testing, you might know from very early in development or your child's development that you have an X and Y variation, and it may not have manifested as anything yet, right, in behavior or differences in learning and things like that. So it's a way to try to understand what they're useful for. The way, at least in psychiatry, that we even define or use these disorders is based on something called the DSM-5. That's the Diagnostic and Statistical Manual. And honestly, it's really a collection of symptoms that we don't have, like in other fields yet, great ways to confirm a diagnosis. We can't do a blood test. We don't do an MRI. It's based on the behaviors that we observe and see throughout development that will lead to a diagnosis. So at least for our clinic, we really like to think of that as a starting point for discussing what might be happening, right? And so particularly in the kind of intersection between these sorts of psychiatric diagnoses and talking about X and Y chromosomes, it's probably some interaction or some manifestation of things that are arising from having a sex chromosome variation. So, one way to think about it is, it just might be, hey, there's multiple things that happened and, multiple diagnoses that your child may have, and that might be the case. But particularly, based on the research that we have, we're really trying to understand how these genetic variations might be causing some of these other symptoms that we're observing. And I personally think it's very useful to have, I do agree that these labels, these diagnostic labels, are limited, but it's a good way to start having a framework about how to make some evidence-based decisions about treatment if those are necessary. So, like I was mentioning, the genetic diagnosis is often the first thing, right? That's often what we'll know earliest in the development of your child. And then at some point, particularly around school age, you might start noticing that there's either impulsivity, hyperactivity, or inattention. And so what other people might start noticing, either in schools or people who don't know the genetic karyotype of your child, is picking up on some of these things associated with ADHD. That might also emerge in early development or in later development, in early adolescence, as really seeing some struggles with social judgment, social perception, and decision-making, and things that might be associated with autism. And like I mentioned, one way to think about it is, hey, I just maybe got the short end of the stick. Not only do we have a genetic variation, but maybe I also happen to have ADHD or autism. And, from a research perspective, we think it's probably all related, right? Something about the X and Y variation is directly increasing your risk for some of these other conditions. So why don't we now sort of go through even what some of these diagnoses are. Like I mentioned, they're typically a list of behavioral symptoms. So I think it's useful to have a general idea of what that might look like. Things like attention deficit hyperactivity disorder, I'll start with that because it's one of the most common. Again, we break it off into both the inattention domain and then the hyperactivity and the impulsivity domain. And you can see it's as simple as just kind of, if you look at just that face value, a collection of whether 6 particular symptoms out of 9 are present in attention. And that might be things as little as, trouble keeping attention on something, doesn't seem to listen when spoken to directly, often loses things, is easily distracted, right? And in the hyperactivity and impulsivity domain, we might see things like, this should be lower as one of the categories, but often fidgets or taps hands and feet, squirms in seat, runs around or climbs in situations where it's inappropriate, unable to play or engage in leisure activities quietly, talks excessively, blurts out answers, etc. So at face value, I think a lot of people might really wonder, well, pretty much anybody could get the diagnosis then of ADHD. And a really skilled clinician, I think, would look beyond just like any one particular moment or context, but really thinking through whether these kinds of symptoms really are representative of a process that has been occurring in multiple domains across multiple times of a kid's life, to make a diagnosis like this. Specific learning disorder or learning disability, these are looking for evidence of challenges in acquiring knowledge in certain areas, so difficulties learning and using academic skills. So there's an important kind of provision here. It's called despite the provision of interventions that target those difficulties. And within the DSM, it might be broken down into separate categories. So things like word reading, it might fall into verbal comprehension, spelling, written expression, calculation, and number sense. And typically for a lot of kids, you won't see this in early preschool development, where it's still normative to have trouble with a lot of academic skills. It's not expected or for that age group, but it'll often start to emerge in the school age years. For some of your kids, it might not even show up until later, because a lot of times younger kids or the schools will naturally compensate using their other skill sets. And so you may not see it until really the cognitive load or the demands get much higher. So for some kids, it doesn't emerge until the end of elementary school or even at a later time in middle school. And it might come into play when there's things like timed tests, starting to have homework that requires reading or writing lengthy or complex reports for a tight deadline, or very heavy academic loads. And like I mentioned before, particularly for kids who have 47XXY, the area that tends to be affected is in the reading and writing domains, although the other domains may also be affected as well. Moving over to autism spectrum disorder. This is, again, a condition where there's problems with social communication and social interaction, and it occurs in multiple contexts of social behavior. And some ways to pick that up might be things like your general back and forth conversation. So language is a very social behavior. We use it to engage with people around us. And it requires a number of kind of complex social cues, being able to listen and respond appropriately to the social piece of information that's given to you, and then to build on that. So that might include things like sharing interests and emotions, or being able to initiate and respond to social interactions in a typical way. There's also a lot of social behaviors that are nonverbal, and part of the diagnosis for this condition is whether or not those are used effectively. So we will often use nonverbal behaviors like eye contact or body language to give context to the words we're saying, or we will do it in place of words altogether. And part of what we do socially is learning how to interpret an expression or a particular eye movement or a particular gesture. And then a more naturalistic form of social behavior that we look for is the ability to build and maintain typical social relationships, whether those are friendships, family relationships, or romantic relationships. Another specific aspect of the autism spectrum diagnosis is there has to be the presence of what we call restricted or repetitive patterns of behaviors, and that can include restricted interests or activities, right? And in the more classic sense for younger kids, what you might often see are stereotyped repetitive motor movements. So people might also call that stimming, or you might see it in lower functioning kids as hand flapping or self-injurious behavior. But it might even be in the way we use speech. So just saying kind of the same phrases over again, or a syllable over again in a very repetitive way. It could also be related to behavior. So a real rigidity or inflexibility about things being a particular way, and being very inflexible about or not being able to understand when things aren't scheduled in a particular fashion or doesn't go the way that they intend. And it might also be very narrow interests that are unusual or unusually strong. So sometimes with kids on the spectrum, they only want to talk about their one favorite cartoon or this one particular type of toy. Like they'll have this immense knowledge about Pokemon or Legos at the exclusion of everything else. And it could also be fairly biological. So a very restricted kind of domain of sensory inputs. And that might be sensitivity to sound, sensitivity to textures, or physical touch. And it might even be things like taste or texture in their diet. A new diagnosis that was placed in the DSM-5, which came out in the last decade, is for kids who didn't meet necessarily that repetitive piece of autism spectrum disorder, but it does still have these impairments in their social communication. And so they have a particular diagnosis now called social or pragmatic communication disorder. And that pertains more to that first category of how they use social information and communicate. And again, here, it's the social use of verbal and nonverbal communication, such as greeting people and sharing information in an appropriate way to a situation. The ability to change speech based on the setting or the listener. So that might include really being able to talk differently and understanding the social context of a playground versus talking to an adult in a classroom, things like that. Trouble following rules for conversation and storytelling, such as taking turns and using nonverbal signals, and inferring information that's not explicitly stated. So a lot of times in our language, we have these more complex social cues. So humor, sarcasm, metaphors, these are all things that are kind of a higher level social use of language. And someone who has a social deficit in this area might meet the criteria for this diagnosis. Many of you will be familiar with the concept of anxiety. It's obviously a huge, very common trait. And the diagnosis itself reflects that. It's the most common psychiatric condition, and up to 20% of people would meet the clinical definition of anxiety over their lifetime. And here it's really the frequent worrying or nervousness about certain situations that are out of context for what the situation is. There are specific types of anxiety. One is the generalized type, which we were just kind of looking at. And this other type is social anxiety disorder. So really having worry that's associated very specifically with social situations. So having to talk in front of others, interacting with peers, fear of how they're going to be judged, rejected, or offending others with their behaviors. And seeing that there's so much anxiety provoked by these situations that they can't manage their feelings through the situation that they're entering. More broadly, I'll talk about psychotic disorders, and this includes things like schizophrenia. Some typical ways of identifying psychotic processes or psychosis are things like delusions. So these are fixed beliefs that really can't be changed. So they can be persecutory beliefs, like the idea that people have or something against you, they're trying to bring you down or get you. Referential beliefs, this idea that constantly people are talking about you when probably they're not. Somatic delusions, thinking that something is clearly wrong with the way you feel or something about your body. Religious delusions, things like that. Hallucinations are actually sensory experiences. They can be auditory or visual hallucinations are the ones that happen, but auditory hallucinations tend to be the ones that are more common or typical. You might also see psychosis manifest as disorganized thinking. So just a real decline in cognitive ability. And this is one of the classic signs of schizophrenia. Grossly disorganized or abnormal motor behavior, and negative symptoms like flattening of emotion and motivation and speech. So I thought it would be useful just to kind of walk through what some typical kind of scenarios might be that represent some of these conditions that we were just talking about. And these are some clinical cases that are actually presented in DSM kind of related literature. So you might have a situation with Carlos, a 19-year-old college student who came to his primary care doctor with academic difficulties. He had started college 6 months ago and had done really poorly on tests and was unable to manage his study schedule. He worried quite a bit about flunking out of college, leading to insomnia, poor concentration, and a sense of hopelessness. After a tough week, he just came home suddenly saying that he thought he should quit. So his mom brought him back to his clinic and wondered whether his ADHD might be causing problems or whether he'd outgrown it. He was seen at that clinic when he was 9, and he was diagnosed at that time as a kid with ADHD combined type. And it seemed at that time he had been in trouble a lot at school for not following instructions, not completing homework, getting out of his seat, losing things, not waiting his turn, not listening. And he had been in trouble concentrating except for video games, which he could play for hours. Developmentally, he'd been slow to talk, but his birth and developmental histories were otherwise normal. So he, in his part of his evaluation at age 9, he had a psycho-ed assessment with a clinical psychologist that confirmed he had reading problems, particularly fluency and comprehension, but he didn't meet the school criteria for a learning disability, which at that time was this gap between his IQ and his academic achievement. So he never got any additional services at school. And instead, he was recommended for medication, which mom didn't want to pursue at that time. And instead, she paid herself for academic support through tutors to help. At the time he comes back, he went back and got further testing. It confirmed that he had reading and writing abilities substantially below what was expected for his age. And it concluded that the testing concluded it wasn't due to intellectual disability, a visual or auditory problem, psychosocial adversity, or a lack of instruction. So he was given a diagnosis of having learning disabilities, specifically in reading fluency and comprehension, as well as spelling and written expression. Here's another situation with Daphne, a 13-year-old in high school who came in because, again, of academic and behavioral struggles. She had difficulty starting schoolwork and instructions, and she was receiving failing grades in math. She often became argumentative or irritable when she was prompted to do academic work, and was also starting to show some school avoidance, getting resistance to attending and wanting to stay home. Daphne got testing done, which showed she had above average intelligence, age-appropriate achievement in everything but math, and difficulties in spatial visual skills. Several years earlier, she had been diagnosed by her pediatrician with ADHD and given a stimulant. She took it for a week, but she seemed agitated, so stopped. At home, the parents were doing a lot of close supervision of homework, which led to arguments and screaming and crying. And she had 2 longstanding friends, but no new friends for New Year's. She generally preferred playmates that were younger than her. And when those friends did not choose the activity, or when they chose the activity or did not follow the rules, she tended to withdraw. She was quiet in groups in school, but bolder with family members. From very early on, she had difficulty with sleep and requiring assurance, and she didn't like new activities. She often spent time with family, no trauma stressors or behavior or developmental problems. So just to go ahead. So an evaluation, she's shy and tense, poor eye contact, difficulty talking about anything other than her plastic horse collection. And after some time, she became more comfortable, said she disliked school because the work was hard and other children did not seem to care for her. She was afraid of making mistakes and getting bad grades and disappointing her teachers and parents. She was preoccupied with earlier failures, and that's what underlied her inattention and indecision. She wished she had more friends, and she always felt this way. These things made her sad, but she denied persistent depressive feelings or suicidal thoughts. She appeared anxious, but was able to be brightened up in the context of talking about things that she enjoyed and with her family. So this is another example where there's probably evidence of a learning condition, this time in math, and possibly also a relationship with anxiety or social anxiety in this situation. All right, so I just wanted to use those 2 scenarios as a way to frame what might be a common laying out of a situation that occurs if you ever do need to engage in clinical services. So what do you expect? What do you want to have happen when you do that? You really need routine screening, particularly for our boys who have X and Y variation. When you know that they might have increased vulnerability, is to constantly be on the lookout so that you can intervene at an earlier point. And part of that process is regularly assessing different behaviors and skills in these domains that we just discussed. It's really challenging. One of the challenges is kids are changing so dynamically across childhood and adolescence. So it's hard to know, oh, well, is this normal for their age? And I find that this is a problem that's often encountered by families where it's their first child who has a particular karyotype. And then they're like, oh, then we had our second kid. And then when we realized with our younger child, just kind of the rate that they're developing, that our older son was really struggling in a lot of areas. And, you know, it's hard to always know exactly what to compare things to. So always keeping that in mind as well. And all of these assessments should really be multidisciplinary, and it should include a number of different domains. So how would you even go about this process? As far as the screening aspect, many times primary care doctors will be able to use different kinds of tools. Primary care has now kind of incorporated a lot of them in their yearly annual examinations, things that screen for social cognition deficits, things that screen for attention problems, things that screen for mood or anxiety disorders. So this might actually be the first place some of these issues might get picked up or detected. And then ideally, your primary care doc will be able to kind of get you into more specialized aspects of care. And ultimately, if you know the symptoms are severe enough, or there's evidence that kind of an intervention might be needed, you might be directed towards a mental health care provider, and that might be a psychologist, a social worker, a psychiatrist, a neuropsychologist. The other big domain for children and adolescents is really the school system, and a lot of times that they might be the first ones who can really provide a fairly comprehensive psychoeducational or neuropsychological assessment, especially in areas where neuropsychologists are in short supply. I think one of the real challenges around using the schools to provide these services is that it really depends from school district to school district how resourced they are to do and address some of these needs, especially I find for the kids who are higher functioning but clearly are still struggling. The schools may pass on really doing an assessment or an intervention. So as a child and adolescent psychiatrist, you know, I want to make sure we understand the mental health care systems particularly and what to expect if you engage in that system. And really, the first visits is really trying to get an understanding of your child or yourself. And that would include getting really a thorough history that covers a lot of things like medical background, family history, how you're functioning in different environments, home, school, and extracurricular activities. And often this would be accompanied by filling out questionnaires or other kinds of screening measurements. In more complex cases, especially things that involve cognition or learning, there might be more formalized assessments like a multi-hour neuropsych battery, and then also looking for other kinds of medical issues that might be contributing to these symptoms. And for those of you who aren't as familiar, there's lots of different mental health providers. So psychiatrists are MDs. They're doctors who typically are involved in situations where medications might be prescribed and therefore need to be monitored, and you know they would manage typically the dosing and starting and stopping a particular medication. There are now a lot of pediatricians who work in this area, and particularly developmental and behavioral pediatricians get a lot of training in using the same kinds of medications. But even primary care practice, since ADHD is so common, a lot of generalists who are pediatricians are now diagnosing and treating ADHD in their offices without referring to a psychiatrist. Psychologists typically don't prescribe medications, although in some states they've been given permission to do so. And a psychologist will often be able to do very thorough clinical assessments and diagnosis and give therapeutic interventions. And those typically are individual talk therapy, family therapy, or behavioral strategies. Similar to psychologists, MFTs, licensed clinical social workers, are also trained to do therapy. Other providers such as psychiatric nurses and ABA therapists may also be very helpful in getting services. A particular domain of psychologists that I do want to mention are neuropsychologists who are trained in testing. So these are the ones who will give those, that full day of testing where they're taking IQ tests and academic achievement tests and memory tests and executive functioning tests. And those can be very useful also. So what's really complex about this whole process is that there's so many moving pieces, both in your kid, and that will dictate how to look for resources and how to interact with the medical system. And this is why multidisciplinary treatment is so important. The way for interventions to be really effective, it really requires in our kids who have X and Y variations, the interaction of a number of different medical specialties. And that also includes non-medical specialties, right? And it might occur in different life settings. So being able to get help either at school or in the home even. And those needs may be different at various aspects of development. So if you're so lucky enough to live near an interdisciplinary clinic like at Colorado, it's a great one-stop shop. But most people don't necessarily have access to all of that. And it makes it challenging because when you think about the development of any child with or without X and Y variation, their needs tend to change and shift as they develop. So especially very early on, some of the things that might come up for our boys are things like motor skills issues, whether it's fine motor, gross motor, or motor strength. And at any given point, language might be pretty fine then. It's under the radar because they're still not talking, but it's still within the normal range. But as they get a little bit older, language might come to the forefront as something that is lagging behind, whereas motor skills with some early intervention and physical therapy got much better. And so in school age, you shift your focus then to doing academic and language interventions through the school. And maybe they don't need as much of that as they get older because they're catching up with all the tutoring and reading specialists that they get at school. And then as they become an adolescent, you start to deal with mental health needs, whether it's social cognitive deficits or anxiety. And then on top of that, starting to deal with things like medical issues. So you could see as a child is aging, there's a lot of different moving pieces that have to be sort of taken into consideration. So I mentioned this as I was talking about the different kinds of providers in our field, but luckily we do have a number of different kind of interventions we can offer. And there's different therapies that exist that are based on different ways of conceptualizing these diagnoses. Probably the most relevant ones and the most common ones that we would encounter in X and Y variation are things like behavioral therapy. So that's really based on trying to understand what causes a behavior and then trying to change or shape those behaviors by removing the triggers and changing the rewards to incentivize positive behaviors that we want and reducing the negative behavior. Another very common form of therapy is cognitive behavioral therapy, and this is particularly effective for mood and anxiety conditions. And that focuses on how the interaction between our thoughts, our feelings, and our actions. For those kids who have specific social cognitive deficits, there's very good evidence for things like social skills training, and those are social programs basically that explicitly teach and provide instruction on how to develop social awareness and reciprocity. And then there's more broadly just psychosocial therapies which focus on different developmental stages. Outside of the field of psychiatry, but equally important, are the related fields of occupational and physical therapy, and that can help a lot with the motor issues that we discussed, executive functioning issues, sensory issues, and speech and language pathologists who really help around anything related to language. And like I had mentioned earlier, a lot of the education for kids and adolescents are going to happen in the school environment. And so the interventions academically are going to be structured around the learning environment. So specific learning disorders and other conditions are protected legally under the disability legislation, the IDEA Act. And so that means schools are mandated to provide services to address needs of kids who have these issues. And that comes in the form of something called the IEP, the Individualized Education Plan. Some of you may be familiar with that already. And that's something that can be requested through the school system formally to get accommodations. A lot of schools will also do informal school accommodations. There's things like the 504 plan. They might, as part of this whole process, be able to provide extracurricular assistance, pull-outs or push-ins. There's different academic models of how to provide additional academic support. Testing and achievement assessment throughout, and also accommodations. And then both within the school and outside of the school, there's increasing attention and services now to things like organizational skills or executive functioning coaching. Medications might be helpful for some of your kids who may have psychiatric diagnoses. And if there's specific target symptoms, there's limited data right now as far as really understanding specific to X and Y variation, whether medications work the same way for these conditions. But we're using them with the idea that they will be effective in similar ways, although probably that's not fully accurate, but more research really needs to be done in this area. And it's important to really have a clear sense of what the end goals are and the targets are for treatment, and then to treat along those ways. Just to touch on some of the more common disorders, for ADHD, medications do show a very high rate of efficacy. So as high as 60 to 80% of kids who have an ADHD diagnosis will have some response to medication. The most common ones that you'll hear about are stimulants. So those are things like Ritalin or Adderall and Strattera. Other common ones you might encounter are clonidine and guanfacine, things like that. For ADHD, behavioral therapies can be effective. Organizational skills, parenting strategies, school interventions. There might be small effects for things like eliminating red food dye, particularly for hyperactive symptoms, and fatty acid supplementation or omega-3s. Some things that are very under active kind of study right now are things like cognitive training and neurofeedback. And there's good research now that's being done by Dr. Tartaglia, Nicole and crew about how testosterone replacement might impact some of these outcomes. For learning disorders, there's really no indication that medications are useful, and therefore the interventions are primarily geared towards psychoeducational strategies. So tutoring, modifying the learning environment, providing accommodation, assistance, and using technology in the classroom and for studying. For social cognitive deficits, the interventions, again here, are really structured around early intervention, primarily behavioral therapies. So like I mentioned, social skills training groups are very well validated now. Applied behavioral analysis, which is the behavioral therapies and treatment, psychosocial skills groups, and things like cognitive behavioral therapies or sensory training might be helpful. Medications can be helpful. It doesn't change the actual symptoms probably, but can help manage symptoms related to having social cognitive deficit. So if there's irritability, rigidity, self-injurious behavior, medications might be effective for those associated symptoms. And then for anxiety disorders, again, the first line treatment is talk therapy, cognitive behavioral therapy. And for mild to moderate symptoms, it's probably just as effective as medication. And then in more severe cases, then probably cognitive behavioral therapy plus medications will be indicated. And so the ones you typically will see are things like SSRIs, which have been around a long time. That class of medicines are things like Zoloft and Celexa and Prozac. And then there's other ones that are less common if the SSRIs are not effective. Treatment for psychosis tends to be much more related to medication again. And this is a group of medications that are most commonly used are in this group called the atypical antipsychotics. If you have symptoms of psychosis, you tend to be pretty familiar and engaged with the mental health system, so I won't spend too much time on that. So just to wrap up in the last slide or two, I think I've probably overwhelmed you with a lot of this information and discussion, but in the end, most people will not know what X and Y variation is. They will have no understanding of the teachers, and even your medical providers will often not know where to start once, even if you tell them the diagnosis, they'll say, oh yeah, I think I've heard about that once. And so a lot of advocacy and care coordination and case management, if you're not near one of these interdisciplinary clinics, often falls on the parent. The parent becomes the expert, the social worker, the case manager, the care coordinator, and they're the ones who are managing across psychiatry, psychology, neuropsychology, endocrinology, developmental behavioral pediatrics, and reproductive endocrine. And they're the ones communicating with the teachers and special educators and tutors and advocating at the IEP plan meetings and trying to get their kids into the state and federal resources in your area to get early interventions and things like that. And an incredibly important piece is when the parent is coordinating all of this complex medical care and the additional challenge of, as your child is developing and becoming an adult, how to transition them to be able to manage that care themselves as they become an adult. And this is, I think, one of the big gaps is that transition. And as a field, we really need to do better, especially in our kids who may be less mature or might have either learning or intellectual challenges that might make it more complex for them to manage that as an adult and how to be able to participate in their care or get them to learn to manage their care as they age. So that's my wrap up for the talk. Just want to thank all of these great people in our center, including Dr. Alan Reese, who's been associated with Axis and been doing sex chromosome aneuploidy research for many, many decades and many years. And we are both very kind of honored and privileged to be participating in Access and the important work that they're doing. So thank you. I'm happy to take any questions.
We have a few questions. One question concerns whether or not you know of a tendency for young adults with Klinefelter syndrome to have Parkinson's-like symptoms and Parkinson's-like tremors.
So that's a great question. I feel ill-equipped to answer because I don't study so much the later stages of development. From off the top of my head, off of my understanding of the literature, at least in earlier stages of development, you don't see that. There are motor symptoms that are associated with genetic conditions, so it's a valid question. You might see Parkinson-like symptoms with some of the medications that are often prescribed in some of these conditions. So in particular, the antipsychotics, the atypical antipsychotics. So it might be associated with that, but I don't think I can answer that without going back and checking. And it would probably be, again, in later adulthood.
Okay, I have some other questions that have been texted and emailed in.
Yeah.
From some parents. For a young adult with XXY, where can I find non-medication treatments for schizoaffective disorder? Medications have had prohibitive side effects. Same question for anxiety disorder.
So the anxiety disorder one is easier to answer, I think, in the sense that there are a lot of great evidence-based psychotherapies for managing anxiety disorder. So again, I think I'll highlight in particular, although a number of ones might be effective, the ones that I think have the best evidence is cognitive behavioral therapy. And I would advise that family for a young adult with anxiety who doesn't want to go on medication is to find someone who is really knowledgeable with cognitive behavioral therapy, CBT models. Schizoaffective disorder is more complex in the sense that when it goes untreated for some time, there's some idea that it predisposes you to have less well-controlled symptoms as they get older. And at least from the evidence we have is medications are probably much more effective than other kinds of therapies right now. So it sounds like one of the issues is side effects, and I would really encourage that family to work closely with their doctor to see if they can come up with some medication solutions that don't have the same side effect profiles, to try maybe different kinds of treatments that are medication based. There are other interventions that might be partially effective or can be very effective for some people, but might also equally sound intimidating. Those are things like ECT or electroconvulsive therapy. There's a lot of kind of investigation now around use of TMS. It's like basically a magnet that is for mood disorders. That you it's very non-invasive. Like you sit in a chair and a magnet clicks over your head. You do it several times a week, and for some people it stimulates their brain in a way that helps them just their mood get better. So that might be something to investigate. But I would strongly say with schizoaffective disorder, particularly if there's psychotic symptoms, it's important to have someone following along and managing and monitoring those symptoms.
I have kind of a long text message that I'm going to try to shorten. It's from a parent concerned about whether or not a major mood disorder could present differently in XXY. Apparently this child had mood swings and ADHD and anxiety, as well as an autism spectrum disorder diagnosis.
Mm-hmm.
But he was relatively stable and wasn't really on any medications through high school except for stimulant for ADHD. However, when he went away to college at age 22, after 3 years in community college, he seemed to be unable to take the pressure of full-time college and living on his own.
Mm.
After the first term, he became manic and he was hospitalized.
Mm.
A diagnosis of bipolar disorder was made, and he was treated with Abilify.
Mm-hmm.
The parents say he quickly settled down, but then they decided he should continue college at home. He went back to his childhood psychiatrist, and they gradually decreased the medications. And the parents say that he has been without taking any medication now for 6 years. There aren't signs of bipolar disorder.
Mm-hmm.
He works with a job coach helping him, and he is able to live on his own with a private agency helping.
Mm-hmm.
But the parents are asking is it possible that XXY and distress can present as something as serious as bipolar disorder and then disappear?
That's an interesting question. For classical bipolar disorder, it is very unlikely that it disappears. It tends to be episodic, and it comes off and on repeatedly, right? So I agree with the parents here wondering about whether that was appropriately diagnosed in the first place, given that it was sort of this one-off occurrence and didn't recur. Mm-hmm. And it's been such a long period of stability. So I can understand, like, you know, there might be some skepticism around that. So I think it's a valid thing to consider. I can't, you know, I just want to make it very clear, I can't offer real clinical advice on here without knowing any of these adults or kids in person, right? So take everything I say with that kind of warning. That being said, you know, I would also, if I were them, want to get a second opinion consultation, really to have someone look through the records and to see if they were what we would consider classical symptoms of bipolar or manic behavior. because, I think that would guide their future decision about how cautious they need to be about some of these things. Yeah. But I think with ADHD and having social cognitive deficits, certainly some things might appear as really agitation or irritability or kind of behavior that's directed towards goals that might seem at odds. But not knowing the specifics, I can't say. Maybe it was a very classical kind of manic episode, then that would be very different, right? But I can appreciate their viewpoint. I think it is worth them asking and getting a consultation about that.
Right. Another question. Do you have any suggestions for older kids that don't think they have problems and don't want to participate with counseling and won't follow through?
Oh gosh, that's such a great question. Yeah, I mean, that's the whole point of adolescence, right? Is they're individuating and making their own decisions. So I think this is a huge area of concern because sometimes as a parent, you're seeing in a lot of ways that sometimes their decisions or behaviors are undercutting or sabotaging their forward progress. So we really try to work with the kids or the families to try to get some sort of alignment or incentive that will get them into the room or into the office, that they have to see some sort of, it will not work if the kid is, like the parents are picking up on, if the kid is refusing to do certain things, right? And so sometimes it just takes one skilled therapist to really spend some time with a kid and get to what their actual agenda is and to create the agenda around the kids' internal goals and motivations, right? And so my advice would be also for the parents to try to do that, to see what are the things that the kid, maybe they don't think they have a problem, but there might be certain things that they really want to focus on and get through, and to try to use that as the meeting point to get the kid at least to start seeing a therapist for that purpose. And then the therapist can start guiding towards the shared agenda with the parents as well. If that doesn't work, sometimes we even just encourage the parents to just go to the therapy and to work with a clinician and trying to adopt different strategies and influencing things from adapting the parenting structure or what the parents are able to do to the environment to either get the kid eventually to engage in care or to kind of manage some of the things that they're concerned about and how they can change some of their own structures and frameworks at home.
Okay. There was one last question. Are there any medications to treat aggressiveness?
Great question. Yeah. So especially in kids who have neurodevelopmental conditions, there is evidence for medications and being helpful for aggression or agitation or irritability. In lower functioning kids, or kids who have neurodevelopmental disorders, that tends to be in the class of medications called the atypical antipsychotics. So that's things like risperidone or Abilify. That's probably a first start for a lot of people. The other thing to really think about is where is the aggression coming from, and really trying to understand that behaviorally. And this is where having a good behavioral analysis might be helpful, or in higher functioning kids in starting therapy and doing some kind of insight work about trying to understand where some of that aggression is from. Is it actually just a manifestation of impulsivity, or is it a manifestation of depression or anxiety, right? So I think those are all important kind of pathways to follow.
Okay. I believe that this will be available as a recording on YouTube. I don't know if there's any possibility that I have some questions about whether or not the attendees would be able to get the slides. Would it be possible to provide the slides and they could be emailed to the people who attended?
Sure, I'd be happy to do that.
Okay, all right. I believe that if there are no more questions, and there don't seem to be, thank you so much, Dr. Hung, and thank you to all the attendees.
Thank you, everyone.
Okay, right. Good night.
Good night.